Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Hey everyone, welcome to this special Gastro Girl podcast. We're producing it in tandem with the ACG's Patient Care Committee. And today we're going to be talking about, why is my stomach always upset? What patients should know about functional dyspepsia. Today's guest is Dr. Scott Gabbard, who's a leading gastroenterologist at the Cleveland Clinic, where he is also Director of Neurogastroenterology and Motility. He's also chair of the ACG Patient Care Committee. So welcome, Dr. Gabbard.
Hey, Jackie. It's always good to see you, Jackie. I've known you for over 10 years. And
I know.
Awesome.
Can you believe it? It's
awesome.
crazy.
You finally invited me to be
I know. I had to wait.
So thank you.
No, thank you.
I see this all the time, in my practice. A patient will come in, and they're labeled as having GERD, which is, gastroesophageal reflux disease, which is really a problem where acid comes up into the chest, and they'll have been on multiple different GERD therapies, and they'll say, I have GERD. And then, I'll be talking to the patient, and I say, well, don't tell me you have GERD. What are you feeling? And then the patient will say, no, I have bloating. I eat a meal and I get bloated in my, my upper stomach after I eat a meal, or, I'll eat a meal and I don't have chest pain. I don't have burning in my chest. I get stabbing or burning, but it's in my belly, and they'll point to their abdomen. And, I take a step back and I say, no, you don't have GERD. GERD is when acid comes up into the esophagus. You're pointing to the stomach area. You have functional dyspepsia. And so, one thing I see all the time is patients will be describing their symptoms, but then, providers, gastroenterologists or internists or primary providers want to put things in this GERD box because there are a ton of different therapies for GERD. But in essence, the patient has more dyspepsia, and a lot of people just haven't heard of dyspepsia. And one of the problems is there just isn't an FDA-approved medicine to treat dyspepsia. So there aren't commercials on TV,
Oh, yes.
drugs, but there are good therapies for dyspepsia. So it is worthwhile to know about it because there are really good therapies. They're not FDA-approved, but there are ways we can treat dyspepsia.
Okay,
so
this is
that's
great.
why I love talking about this. So
I know, we're
thank you
so
for having
excited
me
to
on.
get into this. So let's back it up a little bit.
Yeah.
What is functional dyspepsia? What is it?
So functional dyspepsia, you can sort of characterize it by different things. Symptom-wise, like I said, it's this symptom in the center of your upper abdomen, be it, either, burning or stabbing or bloating, a fullness, not being able to finish a meal because you're so full and bloated after half a sandwich. So symptom-wise, that's what it is. But, in reality, what's happening in the stomach, there's a lot of factors, and I could go into incredible detail. But one of my mentors, who's a world expert in this, Brian Lacey, he had a great way of simplifying it. And he would tell a patient, you're feeling nerve pain in the stomach.
Oh, wow.
And it's way more complicated than that. But in essence, they're feeling overly sensitive nerves in the stomach. Some people have a cast iron stomach. They could eat the hottest peppers and hot sauce, and they're not bothered by acidic foods, right? Those people have really dull nerves, right? They can eat anything and they don't really feel it. Whereas there's some patients who, even a little bit of acidic, orange juice, which does, the acidity of orange juice is 1/100th of what your stomach makes. Or even the slightest amount of spice will set them off and they'll get, stomach pain. What's the difference between those two people? The people with the cast iron stomach and the people who have so sensitive to everything. And it's really like nerve sensitivity. Some people have a really dull nerves and they don't feel anything and they don't complain. And some people have super sensitive nerves so that any little thing sets off those nerves and you get nerve pain. Again, way more complicated than that. But if you want to break it down and simplify it as much as possible, that's where a lot of these issues come from, is overly sensitive nerves.
So if I eat something and I feel full and it just feels uncomfortable, but it's not in here, it's more here, it could possibly be functional dyspepsia. So it feels like a stabbing or an ache. Is that correct?
Yeah, absolutely. Yes. So, so there are sort of two categories of functional dyspepsia. And I've sort of mentioned them before. You've got the pain predominant, so like stabbing, burning pain. And then you've got the people who get real full and bloated even after normal, amounts of food. And they're a little bit different pathways. The pathway of the stabbing and burning is like nerve driven, like overly sensitive nerves. I tell patients, it's like, if you have any friends with diabetes and they have neuropathy, right? Neuropathy is nerve pain, and they get this burning in their legs. You can get the same thing in the stomach without having diabetes. On the other hand, you get these patients who, say, I used to eat a full meal. Now I eat 5 bites and I'm full and I can't fit anything more into the stomach. And they've had normal scopes and there's no big ulcers. There's no blockage in their stomach. And what happens is they have a muscle problem of the stomach. So when you eat a meal, your stomach, the top part of the stomach called the fundus, opens up and expands, right? So you don't feel full and bloated. And we know this, the fundus can really expand, right? I mean, you've seen those people on TV who eat like 70 hot dogs, right? So the fundus can expands more than most, but like the fundus should open and expand. So they've done studies and found those patients who get full and bloated, like immediately after a meal or during a meal, often their fundus doesn't relax. And so they really have a muscle problem where the stomach just can't open. And that also fits in the functional dyspepsia category. So it's a little bit of a combination of overly sensitive nerves in some people, or a muscle that doesn't relax combined with overly sensitive nerves in others.
So this is so interesting. So, before we started recording this episode, we were starting to talk about, how is it diagnosed and how is it different from GERD, and how do you know what you have?
Yeah. So, obviously, number one is, it's important for patients to, describe their symptoms. And, all too often, a patient will come into my office and they'll say, I have GERD. And then the physician, I'm with a trainee, and they don't go any further. And then they just come back to me and they say, oh, the patient has GERD. Then, okay, well, like, what did they complain about? Oh, they said they have GERD. So it's a little bit up to the provider to say, oh, what do you mean by that? But it's also like for the patients, for everyone listening, like, describe your symptoms. So, I have stabbing or burning in the center of my upper abdomen all day and night, or after meals, or, I eat 5 bites and I'm full. I get this bloating and fullness in my upper abdomen. So number one, it's, the diagnosis really is a bit of like listening to the patient. Number two, for part of the what we call the Rome criteria, all of the doctors who are into motility, I guess, get a vacation to Rome every few years, and they come up with the criteria. I haven't been invited yet, but if anyone's listening,
well, you may will.
I'd love to go. So
we have some inside connections there.
Yeah. So, they come up with these criteria. And so part of the criteria is you have to have had symptoms for at least 6 months. And those symptoms, exactly what I've described, the stabbing or burning or the bloating and fullness for 6 months. And then part of the criteria is like nothing else to explain the symptoms, including at upper endoscopy. So many of the patients will come, and they'll talk to their docs and they'll say, I have this burning in my stomach. And the doctor immediately says, you must have an ulcer. Let's do a scope, right? So if we take 100 people who have burning in their abdomen, right? So burning in their abdomen, the doc says, you must have an ulcer. Let's send you up for a scope. Take a guess as to how many of those patients actually have an ulcer.
I wouldn't think very many of them.
Yeah, so actually only like less than 25% of those patients have ulcer, even though, the gastroenterologist is convinced you must have an ulcer. Patients convinced. No, most of the time it's normal, or maybe they have some mild redness in the stomach, but, secret is everyone has a little bit of mild redness in the stomach. I took some Advil the other day, and I probably have some mild redness in the stomach. Like that doesn't mean too much. So most of these patients have a normal scope. So most patients who come in with stabbing, burning, bloating end up having a normal endoscopy, and they fit the criteria for functional dyspepsia. So really diagnosis is based on listening to the patient, following the criteria, and then, not having another good explanation. And it's not to say that this is a made up disorder, right? I mean, this is not a made up thing. It's a nerve problem. We don't have a good test for the nerves. We can't see them with a scope. We can't see them on a blood test. We can't see them on a CAT scan or an MRI. It's a nerve problem. So it's a bit of, having a doctor who's or a provider who's going to listen and make be comfortable making the diagnosis, make sure it isn't anything else, and make the diagnosis.
Do you see patients that maybe, and we love patients, we're always advocating for them, so we're not trying to blame it on the patient, but even myself included, do you think we're not describing things accurately, that we're saying something's burning when it's actually something else?
Yeah.
And that could be, sort of takes us down the wrong path of what we think we have.
Yeah, 100%. Everyone's crunched for time, right? So so people like to, put things in a nice box, and so a lot of docs will just say, oh, you must have GERD. So really it's up to the providers to listen and providers to have knowledge of dyspepsia. And so that's why I try to give talks to everyone and really spread the word on this condition. And then up to the patient too. I think, for a patient, if I had one piece of advice, is really describe your symptoms well and be accurate. Don't just say I have GERD or I have an ulcer, right? I mean, no, describe, like, I have pain, I have burning.
Yes, describe it.
Things.
Yes.
But don't say I have an ulcer. Don't say I have GERD. Really describe it so that the provider can then sort of figure out what's going on.
That's such great advice. So don't play Dr. Google, people, and go and tell the doctor what you have.
Yeah. Unless you Google my name.
Yes. Google Dr. Gabbard.
Yeah.
And no, but seriously, sometimes we try to play our own doctor and try to diagnose what we have and go into the doctor and say, I have this, what can I do for it? Yeah. When we're not paying attention to our body's signs and signals to really describe it in a better way to our healthcare provider. Yeah, so that's good advice. That's really good advice. So what causes functional dyspepsia?
Yeah, it's a great question, right? So for many patients, we don't have a clear cause. But there is a very well-described pathway that is super interesting. And it always kind of gets me really excited when I hear a patient who says, hey, I went to vacation and, I got sick and, I was sick from food poisoning or whatever for a few days. But then, that was 6 months ago. And now I still have this burning or stabbing or this bloating and fullness. And to me, that makes a light go off in my head, because there's this very well-described pathway where you can get some sort of acute inflammatory insult to the gut, be it like a stomach bug, like a stomach virus or food poisoning. And, when that happens, right, our immune system, goes haywire to fight off the bug, right? So our white blood cells that fight off infection, so lymphocytes, eosinophils, mast cells, you guys don't need to know those specifics, but all these different types of white blood cells get activated to fight off the bug. But in the process, right, they're sending signals to each other, right, to stimulate the immune system, get rid of the bug, get rid of the food poisoning. But in that process, when the immune system's all activated, the downstream effect on that, it can cause the nerves to become overly sensitive, and the nerves start firing like crazy. Immune system goes back to normal. So as best we can tell, this doesn't seem to be like a chronic immune problem, though there's all sorts of different research going into what exactly is happening long term. But it ends up, immune system generally goes back to normal, right? So it's not like the patient has a parasite, that we haven't seen, or they don't have an immune problem, but all the effects of the immune system cause the nerves to become overly sensitive. And now the nerves are amplified, right? So, we all, will get burning if we eat a super spicy pepper, right? Or hot sauce or whatever. It's just in these patients with functional dyspepsia, I think of that as they now have an amplifier from the nerves going from the gut up to the nerves of the brain, right? You have a guitar, you strum it, it doesn't really make that much noise. You plug it into an amplifier and it's yeah. So that's sort of the pathway with these patients when they're super sensitive. And so that's how I think about it. But it's often that pathway. And I'll see patients who, they remember, I was great on a Monday and then Tuesday this hit. And then that was 6 months ago. And ever since then, I haven't been feeling good. And in my mind, I go through that pathway and I say, boy, it sounds like you have this, post-infectious, you had some sort of inflammatory thing and now you've got this nerve problem.
Wow, that's so interesting. Now, are there other factors that could smoking or diet, does that impact functional
Yes,
dyspepsia at
there
all?
are some other factors. There are things that put patients at higher risk to get nerve disorders. So having a family history actually may put you at higher risk, and there are some genetic components. So, I had read a study, a while back. There isn't a commercial test for like a gene that I can, order and
Right.
find out if you carry this, but there are certain genes that put patients at higher risks that are actually inherited from mom, maternally inherited things. And so I'll talk to patients, they'll say, yeah, my mom had this or, something.
Right.
So there are some genetic factors. And, some patients have other nerve disorders. So you think of other nerve disorders that are common that people may not realize are nerve disorders. So migraine headaches. Migraine headaches are nerve disorders in the brain, right? Nerve pain in the brain. Fibromyalgia. Fibromyalgia is nerve pain in the muscles and joints. Interstitial cystitis is nerve pain in the bladder. And, chronic fatigue syndrome is like a systemic nerve disorder.
Right.
So many patients have these overlapping nerve disorders. I forgot probably one of the most common ones, IBS. IBS is a nerve disorder of the colon and bowel. Again, there's other factors, but the nerves are clearly at play. And so many patients have these overlapping nerve conditions. There are a lot of other factors. They've looked at outbreaks of like food poisoning, in communities that have had like, food poisoning in the water system. Mm-hmm. And it turns out about, 10% of patients, after an outbreak of like food poisoning end up with, functional dyspepsia or irritable bowel syndrome. So there's all these risk factors, that come into play. And I wish I could say smoking and diet was a risk factor. But to my knowledge, it isn't as big of a risk factor as some of the other things. I always look for any excuse, try to get patients to eat healthier and not smoke. This isn't one of those reasons. There are a lot of other good reasons.
Yeah, exactly. So first of all, two questions, before we move into our next set of questions.
Yeah.
First of all, how is it diagnosed? How is functional dyspepsia diagnosed?
So it's a bit of, the physician or provider, talking with the patient and seeing if they fit the criterion. Do they have, stabbing, burning pain or this fullness for 6 months? And then, part of the criteria is no other cause, including at upper endoscopy. Now, the ACG has really good guidelines on like who should get a scope, right? And so actually the risk of stomach cancer or esophageal cancer is very, very low for anyone under the age of 55. So the ACG has guidelines that, if you're under the age of 55, you probably don't need a scope to look for cancer because your risk is so low. Unless there's some other thing, like if a patient can't swallow, food's getting stuck and we're worried about a mass fall, like that's different. This is just like burning, stabbing, and no other like worrisome symptom. So over the age of 55, and you have this dyspepsia, you should probably get a scope. You should get a scope and make sure there isn't anything that would put you at risk for cancer.
Yeah, because there's a lot of things that overlap. So you just want to make sure.
Oh, absolutely. Yeah, absolutely. Under the age of 55, the ACG recommends checking for a bacteria called H. pylori. H. pylori is a bacteria that huge prevalence worldwide, 60% of the world's population. In the US, it's probably closer to 20-25%. And H. pylori isn't all bad. Actually, H. pylori, for the majority of people with this bacteria in the stomach, doesn't really cause many issues. And it may protect against certain things like esophagus cancer. But H. pylori in certain individuals, in certain strains of H. pylori, can cause stomach ulcers, can cause inflammation, can cause dyspepsia, that burning, stabbing pain or bloating. And it does put people at an increased risk for stomach cancer. Protects against esophagus cancer, but it puts you at increased risk for stomach cancer. So, if you have dyspepsia, the recommendation is to get a test for H. pylori. And then if you find it, treat it. What's really interesting is actually the response rates aren't 100%. So, docs like to think, oh, I found your H. pylori, we're going to treat you and you're going to be better. Actually, more often than not, it may not fully treat the dyspepsia. But there's many patients who you get rid of the H. pylori and their dyspepsia goes away. You really did cure them. But it's not all the time. And in fact, probably the majority of people who have dyspepsia and get their H. pylori treated may still have continued symptoms despite getting rid of the H. pylori. And so it's tough in those patients because they're convinced that their H. pylori is back. They're feeling it. We do test after test after test because they keep wanting to test for the H. pylori and it's negative. We got rid of it.
And what's the test? Is it a breath test?
Yeah, there's a couple different tests. There's a breath test that's very accurate. There's a stool test that's very accurate.
Oh, interesting.
And then there's you can take a biopsy and either send it to the pathologist, the microscope docs, and they can stain for it, or you can take that sample and test it specifically for H. pylori without having a pathologist.
Is this in the stomach? You're going to biopsy
in the stomach? Yeah, you biopsy the stomach during a scope. The ones that don't require a scope are way more cost effective.
Yeah.
So again, if you're under the age of 55, you do a breath test, you do a stool test. There's a blood test, but the blood test only tells us if you've been exposed, not if you have it. So I would caution against doing a blood test. Do a breath test or a stool test. You have to be off of proton pump inhibitors for 2 weeks in order for it to be accurate. So
and your healthcare provider will run that, make sure you do all that. But this is good to know for patients that it's non-invasive. It's
so for the majority of patients, we can do it non-invasively and have our answer. And then if you've got dyspepsia, you've got those symptoms, nothing worrisome. You're not losing weight unintentionally. You're not having blood loss. And you have a negative H. pylori. You've diagnosed functional dyspepsia. So they fit the criteria, and then we can get to treatment, to getting them feeling better, which again, like I mentioned before, there's no FDA approved medicine, but there's a lot of treatments we can give off label that are safe, that are not expensive, and that are super effective.
And that was my next question. You read my mind.
How did I know?
You're so good.
There's different therapies depending on what the patient's major complaint is. Again, is it in the stabbing and burning, or is it in the bloating fullness? So most people, most docs will put patients on a proton pump inhibitor. Proton pump inhibitors, which are approved for reflux, again, more for the heartburn, acid regurgitation. Right. Proton pump inhibitors decrease acid production in the stomach. And most patients, I see are getting prescribed or have gone over the counter and started proton pump inhibitors. Right. What's interesting is that proton pump inhibitors don't work the majority of the time, believe it or not. Some patients may feel partially better, but not fully better by just decreasing acid. So again, it's not fully an acid problem with functional dyspepsia. It's a nerve muscle problem.
Yes, that's so. It wouldn't work.
Yeah, so many patients, are on PPIs. Some, it does completely resolve them, but many patients are on PPIs for years for their dyspepsia, and they're only getting partial benefit. Or I ask them, do you feel any better? And they say, no, I've been on it for 3 months and I don't feel any better. That's when I take a step back and say, boy, it doesn't sound like this is an acid problem. Doesn't sound like this is reflux. This is, functional dyspepsia. So in patients who have failed proton pump inhibitors and still have that burning and stabbing pain, we'll often use what's called neuromodulators, which is the long term for medicine that affects the nerves, medicine that changes the way the nerves fire.
Yes.
And the one medicine that has been studied, and this was a large, study sponsored by the NIH, almost 300 patients. It's now about 8 years old.
Oh, wow.
Found that an older antidepressant actually worked amazingly well. So an old antidepressant called amitriptyline. It's in the category called a tricyclic antidepressant, which again, you don't need to know the specifics, but it's not in the category of SSRIs or SNRIs that are more used for depression or anxiety now. Tricyclics are older, been around since the 60s. They don't really work for depression, so we don't, it's not first line for depression. And they used to use doses up to 300 milligrams to treat depression. We start with 10 milligrams. And in the study, went up to 50 milligrams. But I'll often in my clinic, my practice, again, off label, start 10 milligrams and increase patients very slowly. And it's not because they're depressed. It's not because a patient's anxious. All the time I get patients who will say, oh, my doc started me on an antidepressant, but I'm not depressed. I said, no, that's not why your provider started the medicine.
Right.
The reason is that depression and anxiety, the major neurochemical involved in anxiety and depression is serotonin, right? Serotonin, major chemical involved in anxiety and depression. Guess where 95% of the body's serotonin's made? In the gut.
Yep, in the gut.
And so medicines that modulate serotonin and norepinephrine, different neurochemical, change the way the nerves in the gut fire. They decrease that nerve pain. So a very, very low dose of amitriptyline, which again isn't for depression, it's way too low of a dose for depression, but a very low dose can change the way the nerves fire. And it's been shown in the NIH-sponsored study to help with that like burning, stabbing pain.
Oh, that's interesting. It makes sense. It's logical.
Yeah,
but
it's all about explaining why we do it. Because again, if I just put a patient on an antidepressant,
they're like,
rightfully so, is going to say like, I'm not depressed. Like my doc thinks I'm crazy. And it's like, not, you have to explain why we're doing it. So that's more in the like stabbing and burning category. In the bloating and fullness category, we have a couple alternative medicines that do help. Not alternative therapies, but different medicines than
options. Options.
Yeah. One in particular that's really interesting is mirtazapine. It's an older antidepressant as well. Works differently, but on serotonin, but a little bit differently than amitriptyline. And that one's been shown to help with like bloating and fullness, but it really helps in the patients who've lost weight unintentionally. So sometimes we get patients who say, I can't eat and I've lost 15 pounds and they don't have any room to lose more weight. We'll often use mirtazapine because it helps with the bloating, the fullness, and it helps patients regain weight, helps you improve your nutrition. So in the patients who have poor nutrition, losing weight, mirtazapine is a great option. There's patients who have bloating and fullness. I used to eat a full sandwich and now I can only eat half a sandwich. Or, I'm in Ohio, right? So we love our Coney dogs, right? Our chili hot dogs. And they're like, yeah, I used to be able to eat 3 chili dogs. Now I can only eat 1. Like you really don't need to eat more than 1 hot dog. But if you really wanted to, and you wanted to be able to like be, not have this fullness and bloating after meals, there's an anxiety medicine called buspirone, which again works by serotonin differently than amitriptyline, differently than mirtazapine. And what's really interesting, this is a great study out of Belgium, where they took volunteers and a total side note, like when you read a medical study and you see all the volunteers are like 24 years old, it makes me wonder, they're like, oh, med students who wanted an extra buck. So they like tortured these poor med students. They put a catheter in the nose down into the stomach, blew up a balloon as large as the med students could tolerate, then gave them buspirone and they were able to blow it up like 35%
and they didn't have any
larger.
pain.
It was because it relaxed the muscle. So buspirone, anxiety medicine, but because it works by serotonin, in particular, this one receptor of serotonin, it tells the stomach muscle to relax. So it opens up the stomach so you can tolerate more food. So we'll often do buspirone before meals for the patients who have this fullness, this bloating. I can only eat 1 chili dog. I used to be able to eat 3.
Wow.
And it helps with that bloating and fullness. So those are like the major, some of the major medications we use. But again, not because you're depressed, not because you're anxious. It's to treat the serotonin.
Sorry, I just get so excited because I love this field of neurogastroenterology because, you're talking about these antidepressants medications that were used on the brain. And you mentioned earlier that most of the neurons are in the gut, right?
Most of the body's serotonin's in the gut.
Serotonin's in the gut.
The gut has billions of nerves, not as much as the brain, but it has a ton of nerves. And so a lot of our symptoms are driven by overly sensitive nerves. And that's something that is frustrating for patients because you can't test for that. Doesn't light up on a CAT scan, doesn't light up on an MRI.
But it's so interesting when it makes sense when you're using drugs to address that. The same way you do for anxiety and other things in your brain.
Yeah. And it's like, it's a good thing there's less stigma about using these medicines than there were 20 years ago, but there's still stigma. But I make it very clear to patients, I'm using this to treat the nerves, not anxiety, not depression. You're not crazy. we're treating the nerves. So those are the major medications. There are some alternative therapies. So some herbals and supplements that actually help with the stomach. So believe it or not, peppermint and caraway have been used. I mean, you go to an Indian restaurant and what do they have when you're walking out the door?
Little
Candy caraway seeds, right?
Yes.
They've known for thousands of years, right? Caraway helps, relax the stomach. Same with mints, right? You go to, restaurant and you get a mint. Why do you do that? Well, because it relaxes the stomach, right? It helps with that dyspepsia. So peppermint and caraway preparations have been used, and there are some commercially available ones that you can use. You take it before meals, and it helps the stomach relax. It helps with the fullness, the bloating, and the stabbing, or burning pain. So there are some herbals. There's a preparation from Germany that's peppermint, caraway, and about 7 other herbal herbs that's also been studied in functional dyspepsia. It's been shown to help. And then there's things like gut-directed behavioral therapy and hypnotherapy, which patients, again, I'm going to send you for hypnotherapy. They're like, oh, you're going to hypnotize me? You think I'm crazy? No. Hypnosis and behavioral therapy retrain the way the nerves of the gut speak to the nerves of the brain. And in some studies for nerve disorders of the gut, they work up to 90% of the time. It's unbelievable.
Yeah. And we have a great... Oh, go ahead. Sorry.
Oh, no. The problem is availability. We have a behavioral therapist. Actually, our behavioral therapist is right there.
Nice.
Made sure she's next door to me. Amazing. It's unbelievable therapy. The problem is availability. Not every center has, behavioral therapists. Yeah. Hopefully, we're training them, and hopefully it builds up because it's an amazing therapy. And again, I would love to treat patients and make their symptoms 90% better without medicines.
Well, we have exciting news with what we're doing with Gastro Girl and ACG through GI On Demand. We have an amazing partnership with Mindset Health to offer the Nerva app, which is gut-directed hypnotherapy. And, our director of behavioral health, you probably know her, Dr. Megan Reel at the University of Michigan. She's put together an amazing array of resources. We have some on education.giondemand.com for stress. Diaphragmatic breathing. And so we put together a really nice toolkit for patients and providers so they can recommend to their patients. So we also are right in your corner about
Megan's awesome. I actually share patients with her. Some
nice.
Patients who live in Michigan. So she's fantastic. So
she is fantastic.
Great resource. Again, should be no stigma with this. This is retraining the nerves, retraining the way the nerves of the gut speak to the nerves of the brain. Same's true for acupuncture. I have a colleague who studied acupuncture for a year and now offers acupuncture for our patients.
That's so
cool.
And
it is amazing. It works. Patients will come, they're distended, and a lot of this distension and bloating is from the nerves. Normally, when you feel after a meal, your muscles should contract in.
Right.
And they've done studies on the muscles of patients who have bloating and fullness that come in and, hey, I look 9 months pregnant. I look 14 months pregnant, and their abdomen is all out. And it's a muscle problem. It's a nerve and muscle problem. Their nerves and muscles are essentially their nerves are sending a signal to the muscles, and they're bloating out. So I've got a colleague who does acupuncture, and it's amazing. Like the abdomen will just deflate.
Oh, wow.
Acupuncture. And again, it's not like she pushed the acupuncture needle and she's like letting out air. Yeah. Just literally, it's like
if it were that easy,
relaxing the muscle. So instead of having this belly that bloated out, it just relaxes the muscle, goes away. But again, that's availability and cost, because insurance often doesn't cover acupuncture. So that's out of pocket for a lot of patients. And hopefully, right, we'll get to a point where these things are covered, or there are things we're studying for a different nerve disorder, electroacupuncture. So electrodes used to treat these nerve disorders, a closely related nerve disorder in the esophagus we're studying, but there's electroacupuncture, which you could do at home that we're hoping will help. So down the road, there's going to be more therapies available. There's a lot of research going into this topic now. So hopefully, in the future, functional dyspepsia will be something that docs will say, hey, I think you have functional dyspepsia because now we have therapies for it. It'll be on providers'
people's
minds.
Well, hopefully, I think what we achieved in this episode was to get the word out about possibly what could be causing someone's upset stomach, get the conversation going. And before we close, just to offer some final tips for patients who may think they have this. We don't want you to go crazy out there buying all this stuff over the counter, trying acupuncture. Please don't stick a pin in your abdomen and think the air is going to come out, because that's not going to work. But seriously, like what do you recommend patients do who may think they have this, or someone they love has this functional dyspepsia?
I mean, so take a look. There's a lot of good resources, online. The Rome Foundation has some. The American Neuromotility Society has some web pages. But, think about your symptoms and ask your provider, because again, it's going to be something where patients will be convinced they have an ulcer. They've had 4 scopes, no ulcer. Like, you don't need a 5th scope. There's an ulcer there. Think and just be aware that your symptoms may be driven by the nerves, and there are therapies on the nerves, but don't have stigma on these therapies. They really work. And there's going to be more research, coming, but just keep this in mind, that just because you've had scopes and scans that don't show anything, it's not all in your head. It really could be a nerve problem going on in the gut.
Well, thank you so much, Dr. Gabbard. This has been so interesting, and I can't wait for this episode to drop live. Again, we hope to have you back on again soon. We're going to hopefully do an episode about heartburn and GERD and all that good stuff. But thank you so much. It was a pleasure having you on our show today.
Thank you, Jackie. It's great to see you again.
Great to see you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.